have another distinguished guest that we want to give a few minutes time to, really, and that's Dr. Ricardo Baptista Leite, who's a physician. He's written papers on hepatitis, and he's also a member of Parliament from Portugal. So I think it's very pertinent that we let him or invite him to give a few comments on where we are and where he thinks we should go.
Thank you very much, Chairs, Madam Secretary General for Public Health of Greece. It's a true pleasure to be here in Athens, and I would like to thank Angelos and Charles for their kind invitation. Coming from Portugal, it's great to be in a country where people like the Troika as much as I do. I'd like to start by saying that and congratulating the organizers, because they couldn't have been more up to date choosing such an important topic. I mean, talking about economic crisis in healthcare, ensuring access to public health, and using the Hep B and especially the hepatitis C example is extremely important. I don't need to convince any of you of the importance of Hep B and Hep C in the world when we see 500 million people infected, 1.5 million deaths a year. In Europe alone, around 30 million people are affected, over 100,000 deaths a year. And most deaths are due to complications, in the case of Hep C, of late-stage diagnostics, complications of hepatitis like cirrhosis, like liver failure, and liver cancer. So I guess the first rule of thumb is if it's preventable, prevent it. We have a very safe and effective vaccine for Hep B. And in Portugal, we actually have universal access, and our example shows that it works. And so that would be my message on hepatitis B. Unfortunately, there is no vaccine for hepatitis C, but we are at the verge of being able to cure hepatitis C with new drugs and the newer ones that are coming down the pipeline. We are changing this hard-to-treat chronic cancer-causing viral infection into a potentially curable one. As a politician, every meeting on hepatitis C treatment I go to, people start saying, well, we have a problem now. I'd like to start changing a bit the mindset, because if we look at it really, we are facing one of the most amazing advances in scientific knowledge and one of the most scientific breakthroughs. So the problem is not having drugs that are finally starting to cure safe and effectively. The problem is the costs associated. And there I agree, we do have a problem. And therefore, 1 year ago at the Catholic University in Lisbon, where I had the area for public health, we put together a think tank. And we aimed through that think tank to achieve a consensus on a model for integrated management of hepatitis C in our country. The data we knew about hepatitis C in Portugal alone was enough to justify the need to find a strategy for all of us to work together. A 1 to 1.5 estimated prevalence of Hep C in our country alone. Although people might say it's a bit lower, we certainly have more than 70,000 people infected. 900 to 1,200 deaths a year, mostly due to complications of Hep C, 20 years of potential life lost. Most patients are between 40 and 50 years of age, so they're at the peak of their active lives within societies. And we spend around 70 million euros a year just treating hepatitis C and its complications, and 60% of that cost is spent in late-stage hepatitis. 100,000 euros is the cost of each liver transplant alone. And these numbers tend to rise over the next few years because we know we have, since it's a silent disease, since it has a natural history of decades of evolution, we know a lot of patients are probably infected and don't know. So in Portugal, we currently have confirmed diagnosis of only 30 to 35,000 patients. So we presented the results of our think tank last May 13th, and actually the Minister of Health, through his Secretary General for the Health Institute, announced that he's going to create a viral hepatitis national action plan. So that was, I think, good news. We finally put the train going. At a glance, I'd like to share with you some of the main conclusions of that work, if I may. First of all, and once again, if it's preventable, prevent it. And as Charles Gore normally says, we need to close the cap. We need to close the tap. I mean, if we want to treat more and more patients, it makes no sense if we allow more people to get infected. And to do so, we need to maintain the very well-functioning harm reduction system we have in our society, and we have to make it even broader and make sure that it gets, for example, into prisons where it is not working yet in our country, and where we have a population of 14,000 prisoners, of which half of that population is estimated to have hepatitis C. We need new updates on diagnostic guidelines to include, for example, people who did blood transfusions before 1992, the year at which we started testing for Hep C in blood. We need effective health education for the general public, but we also need effective training for our health professionals in our countries, because we've noticed that many of them, those who are not gastroenterologists, those who are not infectious disease doctors, many times don't have the knowledge that is needed to work with hepatitis C, especially general practitioners, primary care physicians, who play an important role when it comes to screening. We need to establish a referral network which defines who treats what and where. The reference centers should be chosen based on scientific criteria and epidemiology and must be subject to periodic audits. New clinical and treatment guidelines and audits to assure equity and access is fundamental, and these must be based on transparent health technology assessment methodologies so that we can truly fight inequities, even regional inequities, which is a huge problem in our country. And to fight the regional inequities, we also propose that negotiations for the new drugs and the payment of these drugs be done at a centralized level, at the health ministry level, so that we can take away the hospital board administrators from the negotiating table. Because what has happened in other situations is that the ministry is able to negotiate a final price, but then since each hospital board is able to negotiate on their own, some hospitals give access and some don't. And that creates inequities in access. Looking at the models for financing, we have a financing problem, we have a budget problem. So the problem here is not cost effectiveness. The problem here is a budget issue, because we know it's cost effective, but we don't have the money to pay for it. Let's be blunt. And so we propose, and I was really happy to hear the London School of Economics somehow support our ideas of risk sharing. We must only pay for what is curable. I mean, if the pharma says it's a 90% cure rate, then we should pay for the 90% cure rate and not for something else that shows up in the real life setting. On the other hand, we should have a clear cap on how much we want to spend on Hep C. Creating, for example, a fund, using that money, being clear that using clear guidelines, we have this money to be spent so that we can assure that patients have access to the most effective drugs that they need for their genotype, for their level of fibrosis, when they need it as soon as possible. And to do this, of course, this takes a lot of commitment from government. And if you get this full commitment from government, you should expect full commitment from the pharma industry, who really needs to lower their prices. And so I think it's a two-way road where both have to really sit on the table, negotiate seriously, and understand the social impact and the social importance of getting access. And so we really need a socially fair system when it comes to access, and whoever needs treatment sooner should get access to treatment first. We shouldn't leave no one behind. And to do that, we recommend a centralized registry system, which the minister has publicly supported. This system must include all patients with Hep C, with their clinical data, with their level of fibrosis. And the condition to make it work, because in our country, as we saw in this meeting, you also face these kind of issues here in Greece. Many physicians do not comply with these systems. Well, what we have to do is make it mandatory to comply if the patients are to have access to treatment. Finally, we need a national action plan and clear leadership at a ministry level to push it forward, and hopefully we'll get that very soon. And to end off, and I'd just like to leave a couple more remarks. Despite all that we have recommended through our consensus paper at the university, I believe we all need to do more. We need an organized strategic action at the European level. Because despite all the data, high-level decision makers keep asking the same questions. Why treat less people at higher costs when I can treat more people at a lower cost? Which really shows they don't understand what we're talking about. What high-level decision makers should be asking is, why cure less when I can cure more at the same cost? And that is the question. We need to use the scientific evidence and data we have in our power, and we need to be clear that the endpoint, the only endpoint in treating people with hepatitis C is curing people with hepatitis C. No other way and no other path is currently scientifically possible. Lastly, so what should we do at a European level? That was a lot of what we were discussing over these last couple of days. I'd like to share just 4 recommendations for you. First, we need to really fight for joint procurement. Bulk negotiations, bringing countries together can really work. The European Commission, Commissioner Tonio Borg has really been pushing for this. I believe that there is really a path to go there. Secondly, we have international pricing systems in Europe. That has really put prices very high in low-income countries, as my own, as Greece. We cannot keep having Sweden or Norway or other high-income countries comparing their prices with the lower-income prices. That has led to inequities within Europe. Maybe it is time to really face this and create groups of countries within which that comparing system works. Thirdly, we need, and I mean, after hearing the ECDC, this recommendation becomes crystal clear for me. We need to give more power to the CDC so they can play a leading role in the European Union, because clearly the Commission is still holding them back. They need to play a more coordinating role within not only the surveillance that they do so well, but also in the prevention and service provision at the European level. They have the people, they have the capacity, they need the power to effectively do it. I truly believe I'm a strong supporter of the ECDC. And lastly, my last recommendation would be for us to truly look at the European Health 2020 Health for Growth program. If we truly believe, as the program says, and all member states have said it, health is an investment. Health is an effective way to upbeat productivity in the European Union. It's the best way to fight social exclusion. Then we have to have consequence on this program. And one of my suggestions would be to really start to have structural European funds diverted into health. We've built a lot of roads, we've built a lot of railroads over the last decades. Maybe it's time that we start investing in health, not just in hospitals and clinics, but also in treating people and getting programs working. And that takes money. And if Europe really wants to fight inequities between member states, that is clearly the most effective way to do it. Ladies and gentlemen, together I'm certain that we will be able to cure hepatitis whenever possible and prevent new infections in the future. Let's start putting science at the service of the people. Thank you very much.